Intermittent positive pressure breathing. The slings and arrows of fashion have not been kind to intermittent positive pressure breathing, and attitudes have swung from hero worship to ostracism. This technique has been scrutinized mercilessly in the literature and found wanting, usually because it has been used in the wrong way for the wrong patients. Ippb is simply pressure supported inspiration using a non-invasive ventilator such as the bird. Inspiration is triggered by the patient, sustained by positive pressure and followed by passive expiration. Bird ventilator. Indications: patients with atelectasis who are drowsy, weak, or fatigued may benefit from Ippb. Patients who are unwilling, restless, or in pain do not. Pain is not a contraindication in itself, but if atelectasis is caused by pain, it is best to deal first with the pain because muscle splinting will prevent the patient from accepting the positive pressure. Sputum retention may be an indication for drowsy, weak, or exhausted patients, example, those with neurological problems. Excess WOB can also be eased by Ippb. Ippb is not indicated for administration of drugs because it does not offer any advantage over a simple jet nebulizer, and the positive pressure results in 30% less aerosol delivery to the lungs than a nebulizer alone. Technique for the bird ventilator: the nebulizer is filled with saline and tested by activating inspiration with the red manual button. If the aim is to increase volume to the lung bases, patients are positioned comfortably in side lying with affected lung uppermost. After turning into this position, they are allowed to return to normal tidal breathing, then asked to hold the mouthpiece firmly with their lips. They are advised that extra air will flow into their lungs to help their breathing and reassured that the procedure can be stopped at any time, either by request or, if using a mouthpiece, by inhaling through the nose so that the machine is not triggered. The inspiratory sensitivity determines how much negative pressure the patient must generate in order to trigger a low number indicating that little effort is required. For the bird mark 7 or 8, it is set usually at about 7 or so that the patient can trigger inspiration with ease. The flow rate determines how fast the gas is delivered, a low number for a long breath and a high number for a short breath. It is set as low as comfortable, starting at about 7 to 10 to ensure minimal turbulence and optimum distribution of ventilation. Breathless patients need a high flow for comfort. The inspiratory pressure should be set according to patient comfort. Starting pressure may be about 10. Collapsed lung is difficult to re-expand because of low compliance, and positive pressures of 20 cm H2O are considered necessary when using bronchoscopy. The pressure dial should show a smooth rise in the preset pressure at each breath to indicate patient coordination. The patient takes a small breath and machine does the rest, without the patient prematurely stopping inspiration by active exhalation. When the patient's breathing pattern has settled, the pressure can be gradually increased until maximum expansion is obtained without disturbance to the breathing pattern. The physiotherapist's job is to adjust the pressure and occasionally adjust the flow rate to compensate, because flow governs the speed with which the preset pressure is reached. Reassure and advise the patient to allow the air to fill the lungs and do not blow out. Observe the abdomen for unwanted active expiration. Observe the face for discomfort. Observe ribcage excursion to ensure that expansion is improving. Afterwards, wash and dry the nebulizer. Liaise with nursing staff and leave written instructions to avoid the patient or family altering the knobs. The air mix knob is maintained in the out position by a clip, which ensures that air is entrained and 40 to 45% oxygen is delivered. For patients who require high levels of oxygen, 100% is delivered by pushing the air mix knob in. For 24% oxygen, the machine is run on air with oxygen entrained at 2 liters per minute via a needle through the red bung if the reusable circuit is used. Finer adjustments are achieved with an oxygen blender attachment. For Entonox, the air mix knob is pushed in to ensure the patient receives all of the gas. The flow rate may need to be increased with these modifications. The apnea switch should be turned fully clockwise to the off position to prevent operation as a conventional ventilator. The manual button is not used routinely. A retard cap can be used to create a slight positive end expiratory pressure, which the manufacturers claim may prevent recollapse of alveoli. A mouth flange can be used to assist the mouthpiece seal. A mask can be held on the face of semi-conscious people but is frightening and patients need explanations and the freedom to say no. Ippb can be used via tracheostomy or endotracheal tube with inflated cuff, but barotrauma is a risk because of the seal system. For acute patients, the physiotherapist should be present throughout in order to make the fine adjustments needed. Occasionally, well-practiced and alert patients can use it independently. Example, those with asthma or fibrosis who are sometimes reassured by having it available by their beds at night. Ippb is best used for short periods of time, after which other techniques such as positioning or if necessary CPAP can be used as to maintain the lung volume achieved. If secretion clearance is to be included, measures that decrease lung volume such as head down tip or manual techniques are usually inappropriate during Ippb, although percussion may be suitable during expiration if it does not upset the breathing pattern. Troubleshooting: if there is prolonged inspiration and the preset pressure is not reached, check for leaks in the circuit at the mouth or through the nose. If these are not the cause, try reducing pressure or increasing flow. If the preset pressure is reached too quickly, check that the patient is not actively breathing out, blocking the mouthpiece with the tongue or letting pressure generate in the mouth only. If a semi-conscious patient blocks their airway, the head should be slightly extended and the jaw protracted. If the machine triggers into inspiration too early, turn up the sensitivity, check apnea, knob is off. If the machine repeatedly triggers during inspiration, the patient may need a greater delivery of gas by increasing flow or pressure. Check that servicing is up to date. If a reusable circuit does not nebulize, check that the red bung is uppermost. Effects and complications: if the patient is relaxed, comfortable and well positioned with controls accurately adjusted, Ippb should increase lung volume. This increase lasting for about an hour or longer with correct positioning. Compared to CPAP, positive pressure is intermittent and typically reaches higher pressures, thus increasing tidal volume, whereas CPAP increases FRC. In practical terms, Ippb is best for opening up collapsed alveoli and CPAP is best for maintaining the increased lung volume. Ippb can also improve ventilation and gas exchange, and if the patient does not attempt to assist the machine, reduce WOB. Ippb has certain disadvantages compared to the other mechanical aids. It is less effective than spontaneous deep breathing, which is why Ippb is unnecessary for patients who can deep breathe independently. The extra volume is distributed preferentially to areas already well ventilated, because of the passive nature of inspiration and absence of normal diaphragmatic activity, hence the importance of positioning the collapsed area uppermost. It is possible that hypercapnic COPD patients may lose their hypoxic respiratory drive because of the 40% oxygen delivered. Stark et al. Claim that this is not a problem if adequate tidal volumes are delivered, but it would be advisable for patients at risk to be kept under observation after treatment. Alternatively, air can be used as the driving gas instead of oxygen, with modest amounts of supplemental oxygen added, either via a nasal cannula if a mouthpiece is used, or entraining as described above. Air swallowing may occur, especially if there is cheek distension or the patient burps afterwards. This may be relieved by a left-sided lying. A side effect that can sometimes be used to advantage is that techniques such as Ippb, incentive spirometry, and deep breathing can make patients slightly breathless. Even though this is not the aim, these patients can be positioned for optimum distribution of ventilation, then allowed to return to normal tidal breathing. If undisturbed, this encourages comfortable deep breathing using the same slight breathlessness principle as with controlled mobilization. Characteristics of mechanical aids to increase lung volume: incentive spirometry, full patient participation and inspiratory hold, physiological distribution of ventilation, minimal supervision, minimal infection risk, quiet, cheap. CPAP, positive pressure continuous, phase or nasal mask, can accommodate breathless patient, can accommodate tired patient, used for raising FRC. Ippb, positive pressure or inspiration only, mouthpiece or face mask, used periodically, can accommodate breathless patient, can accommodate tired patient, can accommodate semi-conscious patient, used for raising tidal volume. Precautions: these are similar to those for CPAP, although the risk is greater if higher pressures are used. Outcomes: success is in the treatment of patients with reduced lung volume can be measured by the following: improved breath sounds, more resonant percussion note, clearer as X-ray, greater chest expansion, improved SaO2, so long as other variables such as affect this are excluded, example FiO2.